that's very disconcerting.
Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are continuing on with our Brain Health Month. This is a great topic. It is all about Neuroplasticity Explained. I have Fran West here with me. She is a nurse practitioner with Center for Neurosciences. Fran works with us in the hospital. She works with Dr. Tipo, if you saw his presentation last week, and knows so much about the brain. And so I'm so glad she's here today to sort of share with us all about neuroplasticity. How are you, Fran?
I'm well, thank you. Good afternoon, everyone.
So you do
go home when we're done.
You do have an online audience along with an in-person audience. If you're watching from home, please go ahead. If you've got questions for Fran, please leave them in the chat and we will address those afterwards. Fran, I'll turn it over to you.
All right. So again, good afternoon. Glad you all came out. While the weather is still bearable, looks like we're starting to heat up. So very interesting topic today, actually, neuroplasticity. This is very much a developing area, ongoing research on both my side, which is kind of functional neurology, if you think about it. Y'all are going to be having a talk a little bit later from physical therapy, so looking literally at functional aspects, stroke, traumatic brain injury, etc. But you know, the flip side of it, because there's a lot of crossover in the brain between what is psychiatry and what is neurology. So there's a lot of ongoing research on neuroplasticity and remodeling from the behavioral side as well. And you know, kind of the rule of thumb is if we can locate it and give you an anatomic feature and function, then it's neurology. Everything else is psychiatry. But I suspect that's, you know, it's a little too simplistic. Okay, so, oh good, there we go. So the definition, there it is. The ability of the nervous system to change its activity in response to internal or external stimuli. So it's reorganization of both the structure and the functions or the connections. And that's another area that's really evolving in neuroscience, is this concept of neural networks. Not just pathways, but networks and that interconnectivity. Because again, we have had a tendency for a long time to break things down to strictly functional neuroanatomy, and it's just not that simple. So physiologic changes in the brain as a result of our interactions with the environment. Now, they can do this in vitro, in a petri dish with neurons. You can literally put a neurochemical, a neurotransmitter down and see immediate changes in the way those neurons talk to each other. In the pathways they can take, you can see immediately, they'll grow new synapses. And by the same token, if you have one that's doing a certain job and you take away the stimulus, you take away its neurotransmitter or decrease the amount of stimulus it's getting, that pathway will break down, you know, or diminish, and we'll have fewer branches and things. So it's really fascinating. I mean, you know, this is not speculation at this point. We can see this at that very basic level. And it is so present from gestation to death. The old theories, which, I don't know, maybe they still show up in old textbooks, but nobody really believes this anymore, which was after the brain stopped functionally growing, say in your mid-20s or whatever, no more neuroplasticity, right? You know, you have the number of neurons you're ever going to have, et cetera, et cetera. Well, that part is true. I mean, there is some research going on looking at certain deep brain structures and things like maybe there is some regeneration of neurons. But as far as we know, it's not really that you're ever going to grow new neurons as an adult. But what can change is how they talk to each other. And again, developing these pathways, you know, an existing neuron can put out more branches. You don't have to grow a new neuron to get new functionality. And that, I think, is a key component to this neuroplasticity. And some of that you do inside, you know, you are literally thinking about something and trying to change a behavior or develop a skill. Or something is happening to you from the outside, some external stimulus, whether it's physical therapy, whether it's a noxious stimulus, behavioral, whatever, that is causing you to change your reactions. Changing a reaction changes your hardwiring. So when we talk about rewiring the brain, that is truly what we're talking about. Okay, and so yes, you will see this everywhere. This is also, kind of something we'd like to talk about. This Jerzy Konorski, back in the 40s, talked about this concept of neuroplasticity and changing neuronal structures. But it took a while for the science to catch up with, his very true thoughts on the subject. All right, and so yes, as I was saying, neurons can reorganize themselves for a number of reasons. Certainly trauma can do it, but behavioral stuff as well. It does not literally have to be direct physical damage to the brain. Although in my arena, that's pretty much what we're talking about. I do inpatient neurology. I see a lot of stroke. So it means different things to different people. Which side are you approaching it from? In my side, we're looking at people who've had some kind of brain injury, usually stroke, and we're thinking about what's going to happen to them when they get out of the hospital. We figured out why they had the stroke. We had a game plan to prevent future strokes. Terrific. Now what are we going to do about the functional issues? I personally don't manage that because I'm in the hospital. But people then go on to rehab. After rehab, they go home. Rehab doesn't end when you leave rehab. It is an ongoing thing. We'll talk more about timing and why that's important. Okay, so I'm sort of repeating myself, so I don't want to make you listen to me read every slide. So there are two ways of looking at it, sort of the structural neuroplasticity and then the functional. And once again, structural, you're looking at the connections between the neurons, what they call synapses, which is how they talk to them. If you look at two neurons, schematically or kind of conceptually, you'll see these two ends that are like this, and there's this little space between them. That's a potential space. That is the area that neurotransmitters bridge. So one side will be sending the signal, the other side will have receptors. And so medications that we use to treat neurologic disorders and psychiatric disorders affect that process, that relay of transmitters across that space. So you can affect functionality by how much neurotransmitter is there. The pathology might actually be a lack of neurotransmitter. Look at Parkinson's disease, for example. The motor symptoms that you see with it are due to lack of dopamine. It's not that these people lack dopamine receptors. They don't make enough dopamine to act on those receptors. So to treat the motor symptoms, we give them dopamine agonists. We give them we give them dopamine, basically. So you can affect neurons from that component as well. And then kind of on the functional one is changing those synapses or building new ones, because remember, neurons can branch. You don't have to have a new neuron to build new connections. You can build them between existing ones, but you are exerting some kind of stimulus on it that promotes that. So if you know how they say it takes 6 weeks to break a habit or break a habit, change a behavior, but the same principle applies for new skills or new behaviors, And this is where kind of on the psychiatric side, they look at that, because recognizing what your triggers are that have laid down this established pathway. Something happens to you, you see a certain thing, you hear a certain thing that you know how they all say when we're around our parents, we turn into kids again. Just there are certain people that you have just kind of a visceral reaction to and a standard response. You can change those pathways, right? You can actually do that, but part of it is recognizing that they're there, and what are you going to do as an alternative? What are you going to do to block that trigger and develop a new, hopefully more useful behavior as a coping mechanism? And that can, so when you talk about coping mechanisms, that's really what you're doing, is you're rewiring your response to a recognized trigger, that's maladaptive for you, and you want to change that. First thing is to recognize it and then develop a strategy for changing it. And that is how that's how you change your behavior and hardwire your brain. And that works for physical recovery as well. So same thing, these mechanisms that we talked about. So neuronal regeneration, again, not making new nerves, you're making new connections. So that's what we mean by this synaptic plasticity. Neurogenesis and synaptic pruning are things that are relevant in children, because they, you were born with billions of neurons, and those are the ones you're ever going to have in your life. But that is a very real process that goes on in infants and children is that they do prune. If you're not using it, they get rid of it. So yes, by the time you hit like your mid-20s or later, again, you're not making new neurons, but what you are working with is, creating those new channels, those new synapses. And then this, so some of this is kind of the more research type language where we talk about equipotentiality, vicariation, diaskesis. This is literally talking about neuronal behavior. Equipotentiality is where you are affecting those synapses and how they, so this is neurotransmitter stuff. So what are the neurotransmitter that are, pardon me, which ones are active? Is there too much of it? Is there not enough of it? Or is the problem caused by either of those things? And that's going to affect how you treat it. So for example, like Parkinson's, you're going to add dopamine in. If somebody has epilepsy, which is every time somebody has a seizure, it's basically an electrical storm in the brain. And so no matter what epileptic medication we use on them, they all work in their own way. And there are certain families of them, just like with high, like blood pressure medicine, certain subfamilies. But the whole point is what we're trying to do is calm the brain down and stop that cycle of, because once things start misfiring, it's going to spread. So that's what we're trying to prevent. And that, again, is working on that equipotentiality, working on those neurotransmitters and their receptors. So some things are receptor agonists. We want more of it to get through. Some of them are antagonists. We're blocking the effect. It all depends on what the issue is. So I don't want to oversimplify it, but it could get real complicated because once you start talking about specifics, then you're talking about specific disease processes, and that's not what we're about here, not now. Vicariation is, which is a great concept, and once again, not quite as simple as we used to think it was, but it still can happen. We used to think, okay, you got, and this goes back to Galen, right? You have two halves of your brain. They look pretty symmetric and they look pretty much the same. So if there's a problem on one side, the other side should be able to take over. Well, it doesn't really, because we know that functionality depends. That's why anytime you see somebody in neurology, they're going to say, are you right-handed or left-handed? Because that tells us what your dominant hemisphere is. And we know, for example, if you're right-handed, your language centers are going to be on the left. If you are a lefty, you probably share your skills between both sides of the brain more than a right-handed person does, and probably 10 or 20% of lefties still have their major language centers on the left. But, it does tell us something about how you are wired. And it'll also help us back before we had the magic machine that is the MRI. That's kind of how we figured out where people had their strokes. We used to call it like localized lesion. All right, you're presenting me with these symptoms. I have to figure out where in the brain the problem is. So the thing is, though, when you're looking at recovery, we do think that nearby structures, or even ones that are technically not even related, can pick up some of that functionality. If there's an area, you have a stroke or you have traumatic brain injury, that tissue is gone. Forever after, we'll look at your brain and we'll see the scar tissue. So we can't recover that. Our goal is to figure out how do we go around it and build new connections. Diaskesis is this concept, goes back to the neural networks, where you may have a problem here, but it's going to have an effect out here somewhere. And this only makes sense if there is a network involved, right? Because how does my damage over here in my left parietal lobe end up with problems, somewhere in my frontal or whatever? Well, because these things are all very tightly interconnected. I mean, they're literally fiber tracks sometimes, but also just, again, these kind of neural networks that all have to do with how these neurons are talking to each other. So just bearing in mind, again, when we're looking at recovery, we count on the fact that just because the problem is here, if we work on skill set that uses a different part of the brain, it could help the damaged area too. Okay, we just did that. It's just background, so you can actually have those definitions if you want them. And I will tell you, if you're YouTubers at all, there is a wealth of information out there, just really good educational videos from all these different domains, whether it's neuroscientists who are, a lot of them are psychologists by training, whether they're psychiatrists, neuropsychiatrists, stroke neurologists, Physical therapists have some excellent educational stuff out there on just this concept, because they are the people that really do it in the trenches. You know, they take the theory into practical application. All right. Yeah, we talked about this stuff. So the concept of plasticity versus neurogenesis. In our age group, we are not generating new nerves. Once again, let's all be real clear about that. We're not growing new nerves. We are growing new functionality with the nerves that we've got. All right, so a synapse, that little junction I talked about. And that, you know, this is electricity. It's electrochemical stuff. So if you want to go in there and look at, you know, membrane potentials and things like that, the neurochemistry is out there for you to discover. It's a little bit beyond this talk. And that was, and I, you know, if you ever talk to any med student, and I see them all the time in our, you know, in our service, that was not their favorite part of med school. Nobody but neuroscientists really likes to talk about that stuff. All right. And then neurogenesis, so yeah, it kind of grows, and I will go back to neurogenesis, I guess, you know, that more fine definition is, yeah, the growth of new neurons and everything. But you could look at it as new neuronal tissue, but, you know, again, not really applicable to what I'm talking about. Like I said, it's more about building the networks. Okay, so excitatory messages are transmitted, right? That's telling you there's a stimulus and it's getting passed on. Inhibitory, chemical messages blocked. Like I said, this is what a lot of medications are based on, including things like, you know, selective serotonin reuptake inhibitors, SSRIs, right? Everybody knows somebody, they're on themselves, or somebody who's on an SNRI or an SSRI. These are very commonly used antidepressants. They are used for pain management. They're used for depression. They're used for anxiety. They're used for a whole bunch of things. But their whole thing is that they block those receptor sites, so you have more of that chemical in circulation, the serotonin, the norepinephrine, which are uplifting things. They help with mood stabilization. They help improve it. So in that case, you are actually blocking the receptor sites so you can keep it in circulation longer and keep it acting longer. And then modulating. Okay, so modulating is essentially what we're doing with any of these things, which is we are affecting how those signals, how those chemicals get passed. You know, again, whether we're increasing or decreasing, we are the ones doing that. That can be chemically with medication. That can be your therapy as well. And that can actually be things like cognitive behavioral therapy, feedback loops. You know, you can affect these things with more than just medication. And I think that's an important part to remember about like rehabilitation, is that it is more than just physical activity. There is a certain mind over matter that goes on there too. Yeah, so I'm so good at putting this stuff on slides and I don't actually read them when I'm going along, but I promise you I just said that. So, but yeah, we use it for pain management, movement disorders, spasticity, epilepsy. I mean, because what happens out here is controlled in here. That's the other thing too. Everything you ever did in your life, everything you are, everything you will be is based on your brain, essentially, because it is your brain that tells you what's happening in the world, how do you interpret this stuff, and how do you respond to it. It's all here. So if somebody tells you it's all in your brain, you agree with them and move on, because that's true, at least in my world. Okay, so we look at like some examples of how we do this kind of modulation, some of the different ways, which I've already kind of touched on, but deep brain stimulation, that is something you will see in things like Parkinson's disease or people who have very severe essential tremor, which yes, it's a tremor, but it's not a Parkinsonian tremor. So even with a deep brain stimulator, those electrodes actually go in a different part of the brain than they do for Parkinson's, because again, we're trying to fine tune it. We're not trying to, you know, cast a wide net. The whole point is to be as precise as possible, so you're hitting the right thing and not potentially interfering with anything else, because these are foreign bodies. If you think about it, you know, it's just like when you get a pacemaker or a hip or something else, we're implanting a foreign body, and it's not, you know, there's nothing that's without risk. And then of course, yeah, somebody's opening up your brain and doing that, but that part usually goes pretty well. Infection is not a huge deal, but we know that when we go in there and we're in that brain tissue and we start activating these things, and we sort of found out incidentally over time, because people have them, that it can affect things behaviorally as well, including things like depression. So we're seeing more research into looking at that too. Like, can we use these kind of devices and think of it like pacing in the brain? Because again, that's kind of what you're doing. You're applying a stimulus and you are controlling the strength of it, the frequency of it, etc., and where you do it. And the next one, the vagus nerve stimulator, that is something we do specifically for people who have intractable epilepsy, meaning despite the fact they're on multiple medications, they still have seizures, and enough seizures that it interferes with their life. So a vagus nerve stimulator sits here like a pacer, but the wires go this way, and they actually go on the 10th cranial nerve, always on the left side because it's bigger over here. And so it has a coil to block stimulation this way, because if you stimulated the vagus nerve, it innervates your heart and your upper gut. These would be people who would just pass out all the time. So we don't want to do that. But for the epilepsy folks, it's essentially like, because I have a long cardiac background too, it's kind of like overdrive pacing. It can sense when there's some abnormal electrical activity starting, and it will send, we program, how, they're on a cycle all the time. So a certain amount of electricity is delivered over a certain wavelength, we set the frequency, and that's for maintenance. And then if there's any kind of abnormal activity going on, it can sense it, and then it overdrives that. It goes to the next setting above for a full minute to try and break it. And so the idea is for these folks that this is going to, if they do have seizures, it's going to arrest them, so they are, going to be less severe, and the recovery will be much quicker. And over time, remodeling, right? We're changing those circuits, those pathways, so that over time they have decreased seizure frequency. And we know this works because we've been doing them now since the 90s. We should probably have more of them out there. But it tends to be something you see more in pediatric neurology than adults. So transcranial magnetic stimulation, not something I personally have a lot of experience in or familiarity. Is going to be more of an outpatient thing, but and we'll see this in psychiatry as well. So it's transcranial, goes across the head. It's not, invasive or anything else, but it's literally sending out pulse waves and magnetic things to try and change those pathways. And to me, it's almost like defibrillation. You kind of stop everything and give it a chance to reset, and then try to reroute these, abnormal or, pathological pathways. Spinal cord stimulators, the whole point there is it's kind of same principle really as putting capsaicin cream on. If you have a chronic pain condition, you want to block that circuitry that goes from the site of pain up to the brain and back down, because it's the brain that says this is a painful stimulus, and it can up ramp, right? So the more the stimulus there is, the worse the pain gets. And then you get to a point where you have something called allodynia, where you have pain way in excess of the stimulus, because you're hardwired for pain, and whenever anything happens, you tend to overreact to it. So if you put something noxious on there, like hot pepper cream, after a while those nerves are going to get so overstimulated that they just stop responding, and that ramps down the response. So if you're doing that with a nerve stimulator, same thing. You're trying to basically block that pathway and either block it altogether or ramp it down so that the response over time becomes less and less and less, and you get better response to whatever medications you're on, and hopefully over time you will need less medication and hopefully also become more functional, because as you have less pain, you are going to participate in life more, meaning you might benefit from physical therapy. You might be able to go back to walking your dog. You might go back to dancing or whatever it is you want to do. And the whole point of doing any of this stuff is so that you can live your life, right? You want to improve your quality of life. And these things are not first-line therapies. These are for people who have done traditional therapies and are not responding well to them, or not to the degree that we want them to, or that the individual wants to. So, we're just trying to affect some positive change that's going to be long-term, that will really make a difference in quality of life. Okay. Electroconvulsive therapy. Again, I personally, other than knowing some psychiatrists that do it, don't really know anything about this directly. I certainly don't prescribe it, don't perform it, etc. But this, anybody remember Nurse Ratched and One Flew Over the Cuckoo's Nest? Yeah, that's what this is, but they've modified it, and it actually is a great treatment for refractory depression. It's not for everybody. It is all about patient selection. Who is the right person for this? Who's going to benefit from it? But again, it's kind of like defibrillation, right? They deliver that, and it's usually done in a series. It's not like they just do one. And it's not like they take them off all their meds. They're still going to be, this is still a complicated issue to manage. But the idea is they deliver that, and it kind of stops everything, gives it a chance to reset and redo the wiring, redo those pathways. So that's why you do a series of them, and it stays in conjunction with their medication. And hopefully, I don't think any of these things are particularly effective, if you're talking about, whether it's non-epileptic seizures or major depressive disorder, whatever, you need some kind of cognitive behavioral therapy. You need to learn how to think differently and how to respond differently in order to change the brain. But that electroconvulsive therapy, they work synergistically. They are both different ways to affect positive change when just standard therapy has not been effective. Bladder stimulator, once again, neurology, not urology, but very effective because many people out there have neurogenic bladders for a variety of reasons. Could have been spinal cord injury, could have been stroke, could have been, oh my goodness, cancer. You can have chemotherapy, you could have radiation. There are a lot of things that can give you bladder dysfunction. And this has really been a very helpful treatment for certain patients. Once again, it depends on why you have the dysfunction. But that's the idea, is that because the bladder actually has fairly good muscle tone. It's a big muscle, right? And so if you lose that tone for whatever reason, this bladder stimulation along with some other therapies and things that do can help that. And as we all know, there is nothing that is going to restrict your activity more than being like, man, if I go out in public, am I going to be peeing? Am I going to be dribbling? And it's not always an issue of just like a big prostate. All right, here's a little aside. I was on a trip a few years ago, and there was a vet there, and I thought, I'm going to ask, because I always forget to ask my own vet. I'm like, do dogs get prostate cancer? Do they have big prostates? Because I feel like it's a design flaw, right? It's like, it's a terrible thing. And he's like, well, yeah. And I'm like, well, what do you do? And he's like, oh, well, if they get cancer, there's really no treatment for it. He says, but we castrate them. I'm like, okay, that's not going to go over well with humans. But I guess that's why they would probably get it too if we didn't. But in this country, a lot of our dogs are fixed. Okay, and then, we talked about the chemical neuromodulation, that's medication. Chemical neuromodulation is medication. Okay, conventional wisdom. Yeah, we talked about that too. Well, but here's the thing. So there are, looking at studies on this, there was one that came out, I'm going to say, in like 2003 or so, where they looked at this concept of, all right, what can you do with a brain that's over 55? And so, yes, you do have more neuroplasticity if you're younger, like 55 and under. You do aggressive therapy, et cetera. And then this was looking specifically at stroke patients. You get like 67%, that's an awfully precise number, but 67% of like the potential maximum benefit from aggressive therapies. If it was the 55 and older crowd, which would probably be 56 and older, you still got a response. It was more like 50% though, but 50% is half of people, so what does that tell you? That means it's absolutely worthwhile doing these things, because it is not true that you don't have the capacity to improve, right? Or benefit from things like aggressive therapies. If I could just get United Healthcare on, I didn't say that, on board with me, that would be good. All right. So brain machine rewiring stem. Well, yes, we all know that we have changes over time and with age, and that affects you inside the skull as well as everywhere else. So negative processes, right? So reduced brain activity. If you have too much going on around you that's interfering with you receiving the signal, whatever the circumstance are, it's kind of like short-term memory. If you don't receive information well, you're not going to lay it down well, and thus you're not going to recall it well. So if you're looking at something like rehabilitation from a stroke, you have to participate fully in, targeted therapy in order to get a benefit, so it should ideally be one-on-one or in small groups where you all have similar issues that you're working on, so you're working on the same stuff, as opposed to you being like, in a regular exercise class. That's fine when you're your normal self and you're one of like 20 or 30 people in aerobics. That is not going to work if you have a specific problem that needs to be helped. Again, like post-brain injury, like stroke. So you have to fine tune it. And then, of course, if you're at home and you're trying to watch your kids or your grandkids or whatever, that's not going to help your focus and attention either, right? That just sort of makes sense. So when we talk about weakened neuromodulatory control, I guess you could look at that as sort of normal aging to some extent, but then you throw an injury on top of it, and obviously the system is going to work even less. But, by and large, people still, unless they have very specific issues like a dementia process going on or whatever, when we do things like neuropsychological testing and everything, people still can do pretty much all their stuff. They might be a little bit slower at it, but they're still doing it, and they're still doing it well. Or, maybe make a mistake and go down a few moments down the road or go back and they're like, and they catch it themselves and they go correct it. So, okay, yeah, things slow down a little does not mean they're not functional. But really, I always laugh when I read these things because I'm like, anybody who's over like the age of 40 knows this. All right, and then negative learning is, to my mind, the most important thing about that is not to be self-defeating, because we do get negative feedback in many ways. And it is important not to internalize it and let that be our limiter, And I think societally we fight against that a little bit. All right, so our current research, right, we're looking at improvement in functional recovery with behavioral training. We're looking at getting people more engaged, so sensory, cognitive, motor activities. One of the things that I think is very interesting that's come out before now, my dad has had hearing loss since he was a young man. I think he had an injury like in high school football or something like that. But my whole life, I don't remember him not having a hearing issue. Now, he also has been diagnosed with MCI, which he loves to throw out there. I have mild cognitive. I'm like, well, I haven't really seen much of a change in 10 years, so okay. But here's the thing. Nobody ever corrected that, and he didn't get hearing aids until probably less than 10 years ago. I'm not even sure. Half the time he's not using them, so I'm loud, which is good. But one thing we know, it's kind of odd because we used to have the attitude of, well, you wait until it's noticeable, until it's a problem, then you go see an audiologist and they prescribe hearing aids that don't work very well. So our technology for the hearing aids has gotten a whole lot better. But the other thing we figured out is that part of the brain that processes hearing is the temporal lobe, right about right here. If you are not using it for hearing, that is kind of dead space. And now there is definitely a correlation. It is not one-to-one, so don't, I'm not implying that. But there is a correlation with loss of function and cognitive changes and cognitive impairments. So if you feel like your hearing's getting lost or people are getting frustrated with you or whatever, go get it checked, because the earlier it gets corrected, the better. I think that's, and I think, we used to, and same thing with Parkinson's, we used to say, well, we're not going to start you on meds until your motor symptoms are really bugging you because, it progresses, and then we'll have to put you on more medicine. It's like, so, now we look back on it and we're like, now, why do we think that? Because the thing that matters to people is their functionality, and there's really no toxic level on the medication. You can be taking a boatload of it if it's still helping you and you don't have intolerable side effects. So what if you're taking a lot of Cinemet? So, and now, of course, we have deep brain stimulators, so it has changed the game. But the bottom line is, if there's some decline in functionality that you see, get it checked out. It's worth it, especially something like hearing. Okay. All right. So, practical benefits, right, is this ability to learn new things. Because, again, unless you have a dementia, somebody's actually diagnosed you with one of the dementias, unless you had that, you do have the ability to learn new things, whether it's new things like new skills, or whether it's, meaning mental skills, or whether it is a physical skill. That capacity is there in everybody. So you want to enhance and improve, or certainly maintain the ones that you have already. And we all know that when you stop doing something, or something that you used to do before, it's a bit of an uphill battle to get it back. Now, there are plenty of things I've let slide by in my life, and practically speaking, I'm not going to go back and relearn that, but that's okay. Just replace it with something else. The key thing is not to be stagnant. That is bad for your brain. Okay, and then, recovery from stroke, traumatic brain injury. Actually, it could be recovery from other things too. Death of a loved one, changes in your family situation, changes in your living situation. These are all tough things on your brain. So the neuroplasticity applies across the board to all those things. And whether it's physical function, emotional function, cognitive function. Okay. Yeah, so that's what we're doing. We're trying to train how it works. So I'm going to kind of skip over these. They're cute little things, but I have one at the end that I think is a good summation of all this stuff. So things you can do to improve. And we are huge on this. I don't care what you do. There's no one exercise or activity that's necessarily better than anything else. But get out and do something to the best of your ability, whatever it is. If it has to be adaptive, fine. Most things can be adapted to limitations. You have bad knees or something, okay, you're not going to be doing, deep yoga, but you can do something. You can still do stretching. You can still benefit from that stuff. Weight-bearing exercise. Maybe you just start going back and forth to the mailbox, but that's an improvement there, and you can build on it. All those things will help. Stay socially engaged. I've just had to give a talk on dementia, as a matter of fact, and even in folks who have cognitive impairment, for whatever reason, isolation is bad for you. This is why COVID was so bad for people emotionally and physically, because, this is not about being an introvert versus an extrovert or anything else. We are social animals, and being socially isolated is bad for your brain. And part of that is you just don't get enough stimulus to keep it going. You're not firing those neurons, so you're not developing, new skills. You're not developing new memories, etc., because you just simply don't have the stimulus. Healthy diet. This is, whatever you eat is the fuel for your body and your brain. And for us, I think as Americans in our society, the main thing is to just try to limit the amount of ultra processed foods we eat, because we are inundated with them. I don't preach to people like you have to eat this or don't eat that, but big thing would be way, way, way less of the ultra processed foods. Something that more or less kind of mimics a heart healthy diet, which nowadays is considered sort of a Mediterranean type thing. So lots of fruits, lots of veggies, healthy oils, there are a gazillion of them out there. And of course, anything with a chickpea. The Roman army marched on the chickpea. All right, and then your chronic conditions. So can't stress that enough, at least from a stroke point of view. The leading cause of stroke, wherever you live in the world and whatever you eat, is actually hypertension. So you got high blood pressure and the incidence increases with age. Get on top of it, because it definitely, they call it the silent killer for a reason. So, it's going to affect your heart and your heart function. It's going to definitely affect your brain over time. These are changes over time. So if you're aware of it and you treat it, you can live a long, normal life without having it. But I see people roll in the door with a blood pressure of 220, which gives me palpitations. But, and I plenty of times have pulled up imaging, somebody's coming through that's a TIA or stroke workup or whatever. I look at that CT and I'm like, well, when did you have that stroke? I've never had a stroke. I'm like, well, I beg to differ, because I can see the evidence of it. Once you've had it, even if you had a full recovery, never even noticed it, I can see it. If it leaves scar tissue, it's a stroke. And a lot of those happen, and they tend to happen deep in the brain tissue too. And this is a vascular insult on your brain, right? And there's going to be a cumulative effect. This is how people go on to develop things like vascular dementia. You know, it's not something that happens overnight. It's a process that evolves over decades. All right, adequate sleep and hydration. We are a nation of people who can't sleep. And probably my big soapbox issue on that is, who the heck ever thought it was a good idea to put a TV in your bedroom? Bad, especially because now kids have them. And then we got our phones, and I'm guilty of that as anybody. I mean, I literally have to it was one of my Lenten, it's like put the phone down and put it over there. All right, and then yes, and we live in Southern Arizona, so we all know hydrate, hydrate, hydrate. And there's my little bit on hearing aids. I forgot that I'd modified this and actually put it in there. I'm not kidding about the hearing aids. That's a big deal. All right, so these 10 principles of activity-dependent neuroplasticity. This is actually based on an article, Klein and Jones, I think it was, back in like 2008. This is big in the world of physical therapy, stroke rehab, et cetera. And also, even on the psychiatry side, they use it because the principles are the same. Number one, use it or lose it. If you're not doing anything, you lose function. And so that function can be cognitive or physical. Use it and improve it. So, you know, if you're learning a new skill, as we all remember, remember learning to write cursive with the little thingy, the more you do it, the better you get at it. Whether it's knitting, whether it's a language, whether it's walking, whether it's pickleball, whatever. You know, you do it more, you lay down those pathways, you get it hardwired, and then you start to get muscle memory. You know, so you don't have to think about it as much, but you're still getting the benefit from it. Specificity. So this, certainly in the realm of stroke medicine and stroke rehab, has to do with, okay, what is the loss of function? I need to target the therapy to that problem, right? You know, you don't just go in and do generic stuff. It's targeted to what the issues are. Repetition matters. Kind of goes back to the use it and improve it. That's how you lay down those new neural pathways, get those new networks going on. And remember, going back to diaskesis, which is injury might be here, but it could have an effect over there. So, you know, when you do that repetition and you lay down those new pathways and you develop those new skills, we're probably treating whatever this focal lesion was, but you're going to get a benefit over there. And by the same token, if you're doing something that affects this part of the brain here, that loop works the other way as well. So intensity, right. So this is where when you have a stroke, that brain damage, you know, is acute, it's sudden, and there's, you know, nerve death, tissue death that happens. And you know, we try to stop that cascade. That's one of the reasons we want people to get in and get treated. But over those first 72 hours, there's a fair amount of it. But the other thing is, it sets up the brain for recovery. The brain is kind of wired, if you will, for recovery in the damaged area. And so that's why we think it's so critical after people have stroke that they get to rehab as soon as possible. You know, once they're medically stable. Some people have mild enough strokes that we can do it outpatient, but if they need intensive therapy, they need to go as soon as possible. We don't keep them in the hospital for no good reason. Again, if they're medically stable, I want them out of there in like 3 days. Sometimes it takes me 3 days to get the insurance off. But the idea is strike while the iron is hot. If the brain is ready to heal itself and has mobilized its resources to that damaged area, and this does happen because, again, and you can go look it up. YouTube is great because they got videos galore, and any major neurology center, because they can show you on functional MRIs, which is one where they put tracers in and they have people do an activity and they watch the brain light up. We know this happens in acute stroke. Is you get them in there, you get them in therapy, you get them to start working with the damaged area, that whole area where the damage was and around it lights right up. Because the brain wants to heal itself, in a sense. Like I said, it mobilizes its resources, so you really want to strike when the iron is hot. I'm not even sure what that expression means, but yeah. I mean, I know what it means, but I'm not sure where it comes from. I don't know if that's like a horseshoe thing or what. Anyway, timing. So timing, and that's why timing matters. It's not, we used to say, well, whatever function you're going to get at 6 months is what you're going to have. So that's why you need to go to rehab early and be aggressive, etc. That's not really true. It's just that you kind of plateau, but it kind of goes back to the use it or lose it too. If you're not doing it at 6 months down the road, at 8 months down the road, or whatever, that you can actually regress. You can end up kind of back where you were when you first had the stroke if you were not continuing to, and I don't even want people to think of it as therapy. The whole point of therapy is that you recover function, and you want to get as close to your normal function before the stroke as is possible. And thus, 6 months down the road or a year down the road, whatever gains you had, I want you to have that, and then hopefully some more, because you can continue to improve. It's just slower, and maybe a little more frustrating and less obvious, but it doesn't mean it's not happening. And, maybe part of the victory is, again, maintaining function. So salience, all right, what's the relevance? Am I doing the right, and I keep harping on this, but are we doing the right therapy for what the problem is? Is this, if it's, some kind of weakness in the hand or anything, I don't need you doing a whole lot of leg work, right? If you don't have balance problems, if you don't have gait problems, if you have language problems, and you can't use your dominant hand, that's what our therapy is going to target. Because once again, with all those little resources mobilized up in here, they're focused on the target area too. So that's what the therapy needs to do. It's got to be relevant. Age does matter, as we talked about, only in the sense, though, that, like I said, if you're a younger adult or a child, you do have more plasticity. You're going to have more response. But I don't care if you're 85, you can still improve, so that to me, that's always the takeaway. Don't let that be your limiter. Don't let anyone tell you that you're not going to have recovery. And every brain, here's the other kicker that we can't account for, at least not with our current science. Some brains are more resilient than others. Some people are more resilient than others, just going through day-to-day life. I can't tell that from the outside, but it certainly is a factor. I mean, two people can have the exact same stroke on imaging, and they may have very different presentations as far as their symptoms, and what their deficits are. Transference. So we kind of actually almost well, it's not really contradictory, but supplementary to things like salience matters and focusing on it. But one thing we do know, again, that is other parts of the brain can take over for that damaged area. So transference is the hope that adjacent or nearby structures in the brain, or if you're doing a therapy for another issue, that it can still improve some other aspect. So how to think about that? You can get a good example. Or just thinking about interference. So transference and interference, like if you were working on say you're working on speech, right? Somebody has aphasia, they have expressive aphasia. And so we're working on producing sounds, making words, trying to get the here to here, but maybe they also have weak swallowing muscles and things. So if we're working on both the swallowing and those speech things, those therapies are separate, targeted, but they're both going to improve overall function in the face, what we call bulbar function. So weakness in the facial muscles, swallowing, the muscles of speech, all those things will benefit, even though technically those are different therapies. That can apply to different parts of the body too. Like the problem, so interference though, is when you start having coping mechanisms, like, you have a deficit somewhere and you sort of figured out your own way to overcome it. But unfortunately, sometimes that can block you. Like if you have foot drop or something and you're trying to, after stroke, and you're trying to retrain it. I'm not talking about spinal injury, but after stroke, a lot of times the movement's coming from here in the hip, for lifting the foot, instead of you thinking about pick my foot up when I walk, pick my foot up when I walk. You have to really focus on it and do that task so that you can get those new pathways to help that motor control. So we, have to kind of account for that too, is that there's sometimes habits that we pick up that to us seem to make us more functional, but they're actually defeating the purpose a little bit, because although it's compensatory, it's blocking you from focusing on the real problem. Does that make sense? Mm-hmm. Yeah, that's more of a PT thing. That never happens in my, because I'm so early in the sequence, I don't see him at that part, but I know that happens. Okay, so that's probably about it. Now, take this for what it's worth. This gal, I have to admit, I think she's very practical. I like her a lot, but I will say she does kind of plug her own merch in there. But she's a psychiatrist. This gal, fabulous. So she's a PhD psychologist who actually runs her own like neuroscience behavioral lab. But she's fabulous. I mean, she really explains things well. And this Dr. Tara Tobias is, she focuses specifically on stroke rehab. If you have an interest in that, she is a physical therapist. So it does a very good explanation of all these points I've kind of covered. But again, there's a lot of information out there that looks at this, because this is a hot topic for us, because, you know, until we can figure out how to generate new neurons, we got to work with the ones we've got. And I do not personally have a lot of experience with things like spinal cord injury, et cetera, because, you know, we're not a big trauma center. Those are going to go to Banner and go on from there. But, you know, this is certainly an area where, I mean, think about if we can take these principles and advance on them and really get a better understanding and a way of growing these networks in a meaningful way, which, you know, like I said, we've been making some progress with that, but got a long way to go. But, you know, think of how many people now are kind of warehoused, essentially, long-term care, that kind of thing. This would make a huge outcome. I mean, even like I said, I don't do a whole lot of trauma, but I've certainly, over the many years I've been nursing, I've taken care of plenty of people with, you know, cervical and thoracic spinal cord injuries who are, you know, quadriplegic, paraplegic, et cetera. And then, of course, down the road, when they start having complications of essentially being bedbound or wheelchair bound, I see them. You know, and that includes the spasticity, the skin breakdown, the infections, So whatever we can do to minimize those kind of outcomes, we should aggressively pursue. All right, I think that's probably all I have to say.
So thank you, Fran. I'm back. So I had a couple of questions that came in that I wanted to ask you about. One is about neuroplasticity and how it relates to your mental health, such as depression. I know that oftentimes, you know, when somebody has a stroke, that, you know, there can be some depression. How does that neuroplasticity piece play into all of that?
Yeah, and we do actually screen for that. That is actually part of the standard of care, is to screen for depression, because stroke is a life-changing event. Even if you're fortunate enough to come out with a small one, it's scary, and now you're thinking, oh my God, when is the next one going to happen? So, and of course, if you have a pretty severe stroke, again, life-changing. And you may go from somebody who is fully functional to fully dependent. So we expect depression to be an aspect of that. And once again, you know, we tend to break things down to functional, that's neurology. All that stuff that we have a hard time quantifying is psychiatry, but it's the same organ, right? So there is a lot of crossover. And I think that the principle there is still that rewiring. It's first of all, acknowledge the problem. Depression is very real. It often goes with anxiety, mood changes, etc. Yeah, some of that can be related to the actual damage to the brain. The brain has to recover too, just like if you broke a leg or something. But obviously you can't see this process going on, so it's a little hard to grasp conceptually. But the plasticity part is rewiring those negative feedback loops. Like, so recognizing that the depression exists and making a conscious effort to, you know, you can't just go out there and be Pollyanna, right? But it is seeking out positive reinforcement. What gives you pleasure now? What can you do that helps your mood? And part of that is certainly going to be recovering some function, but it's hard work. Therapy is hard work. If you've ever had to recover from, you know, broken bones, any kind of surgery, anything else, it's hard work. And so imagine if your brain isn't working right, and that can include mood. So I think part of this is where you have to pull in your resources, you know, your family support, your friends, things like that. What gives you pleasure? We can help with medication, but that's not going to be the only answer. It really is going to be, you know, what is your own attitude? And that is something that is first you got to recognize it, like I said. And if it's pretty bad and you're just feeling very negative and I can't magically fix that, nor can a psychiatrist. So part of it is how much do you want to change that? And then what tools can we help you with? And that is where really things like feedback, like biofeedback or cognitive behavioral therapy. And once again, we're doing the exact same thing as the therapists are doing with the therapy, which is we are trying to build new, more productive pathways, that make you more functional, and that includes your mood. I mean, it's the same neurons, right? Same neurotransmitters, serotonin, dopamine, acetylcholine, things like gabapentin, which is seizure medication that everybody knows more from neuropathy than anything else. That's an excitatory neurotransmitter. We give that to you, it ramps down the signaling. So like I said, if we give you a serotonin, like an SSRI or an SNRI, we can increase the amount of circulating happy chemicals, but that's only one part of the picture, right? We need to work on the other things. And like I don't think there's a pat answer to that, but it's more about an approach and a mindfulness and that willingness to work on it. And if that means you get to have your chihuahua with you at therapy, fine with me. Whatever works for people. Music is wonderful. For many people, that is life-changing. I mean, you can even go into long-term like memory care with people with advanced dementia. They can still sing. Some of them will, they can remember music. They will enjoy it. Some of them might even be able to pick out a tune on the piano because that's their long-term stuff, which is a different animal. So, did that answer the question?
Yes. Yeah. So I've got some other questions too. Are there some activities that are better for improving specific parts of the brain? So I know you gave sort of a list of different, things that you can do. Is there something that helps specifically with different areas of the brain?
Not like that. Not like you're thinking like, okay, if I want to improve my temporal lobe function, I'm going to listen to Beethoven. No.
Okay.
Not really. But it's overall keeping your brain stimulated. You do need to challenge yourself. If you're in therapy for any reason, like, again, physical therapy for recovery from stroke or, accident, whatever, then you definitely, there is the intensity, the repetition, and that's focused. But long-term, for your long-term brain health and your long-term overall emotional health and everything else, kind of goes back to that social isolation. Does not mean you got to go and hang out at the bar. Does not mean you have to go out every weekend. Every person's personality is different, but you got to stimulate your brain. Take Ollie classes. I was kind of laughing at my mother because she's like, well, I signed up for 4, but I'm not sure I have. And I'm like, really, Mom? You want to go back to college? Because, but the point being that these are things that she enjoys and it gets her out. She has a book club that she's been in for 20 years. They meet once a month. That's not a huge commitment, but these are long-term friends for many, many years. And this is a great thing for them. It gets them out. They get to, they rotate houses. They have to vote on books. It gets a little spicy sometimes. But, so stuff like that. It's not any one thing. It's what appeals to you. Do you like to travel? Go travel. Do you want to learn new things? Take a class in it. And you don't even have to be a formal class. You can do your own research. You can, and this is a town that actually, if we're looking at Tucson specifically, there's all kinds of fun stuff we have. I kind of recently, last year, discovered our Presidio Historical Society. I'm like, oh, these guys are great. You go to a lecture, it costs you $5 or something, go to a museum. We're close enough to Phoenix, go to the art museum, go to the herd, whatever. Like I said, doesn't matter what you like to do. Walk your dog, ride a horse, go to the, if you're a hiker, this is a great state to be in. Just, make sure you take your water. And don't do it in July at noon. But we all know better than that. So outdoor stuff, I think any kind of regular exercise, doesn't have to be the same thing every day, but any kind of activity that gets you out of your house and doing something active. If you like doing your own house cleaning, which I don't, that's actually a good thing, or you like to garden, I don't care. Physical activity is good for you, but also something that engages you, something that you are interested in, that you want to pursue a little bit further. But it doesn't have to be any one specific thing by any means.
So I think you would find, I would bet that many of the folks that are in person today or watching online, they love to come to our classes because they, just like Ollie, they're learning. They're always learning something new, which is why we do this. Do you? Is there any additional benefit by doing maybe two activities, combining two activities together? Like for instance, maybe you're walking, you're doing a long walk and you're trying to learn a new language at the same time. Is it just more about sort of challenging yourself, constantly just giving yourself something new to continue to learn that sort of helps with those neurons?
Yeah, well, now I just don't think I have the bandwidth to do that because I don't think I'll absorb it very well. But doing more than one thing is never bad for you. You do it to the ability that you want, or I mean, to the level that you want. Nobody should be stressed out. But if you like to walk, and I like to listen to music because I have a whole, little playlist where it's a little bit faster tempo, so it makes me walk faster. Plus, I have a dog who's a small tank, and she makes me walk faster. But I also like to listen to audiobooks when I'm doing, if I'm outside or walking with me and not the dog. Language learning is fabulous. It really is. It's, more challenging for some of us than others. But I'll tell you, the best way to learn your own grammar is to try to figure someone else's out. I never had the grasp. And I'm of an age, remember we used to have the diagram sentences and all that. Then they came up with the New English, which I've never grasped. I don't think I understood English grammar until I had to take Latin. Now I got it. 45 years later, I still got it. But I think language learning is fabulous. Now, when you talk about combining two things, most of the time it's kind of hard to do two things at once. But trying to do something like listening to your language tapes while you walk is a great idea. Plus, it also, none of us are as good at multitasking as we think we are. And we know this because there's data that shows that. It doesn't mean you can't do it. And I think for some of us, being out walking, as pleasant as it is, we need some distraction besides the sidewalk. So whether that's music, your listening tape, whatever. I don't recommend doing things like, driving and knitting, for example. Watching TV, you could certainly be doing something with your hands. It depends on how distractible you are. I am very distractible. So for me to focus and do a task well, I can't have other stuff going on. So that's very individual.
Right. Or you might zone out, you're doing one thing, not really paying attention to the other. The last question I have is what's the most promising improvements in brain health and plasticity that you're seeing in research these days?
Let's see. So looking at the most recent thing, I think they're doing a lot more, and this PT is going to be most helpful on this because, again, these are the people in the trenches doing this. But they have really made a lot of strides in doing things like neurostimulation, too. And, again, using, they can use ultrasound, they can use actual electro stimulation and directly to the digits or the limbs in question to try and restore some of that. And very definitely they're kind of feedback things on, I'm trying to remember what this one thing we had, and it was very specific to hands, but this was kind of pre-COVID and got derailed by that. I mean, I'm sure they're still out there doing, but they don't really talk to us about it on the inpatient side. But there are both, again, things like direct nerve stimulation as well as devices that help with the feedback loop from the damaged limb. And most of it's focused on hands because, they try to focus on the thing that's going to give you the most bang for your buck in the short term, that's going to give you the most functionality back. Not walking is a bad thing, but on the other hand, not being able to use your hands is probably worse. So most of the focus has been on face and arm. And interestingly enough, on the brain, those are right next to each other out here. Lower extremities and stuff this way, face and arm out here. But so there's been great progress in that. Even in things like, so if you have a problem with your arm, for example, it's always easier if the damage is on your dominant side because it's going to affect the dominant limb and you're going to be motivated. If you're right-handed and your right hand is weak, you're going to be motivated to work on that. If, on the other hand, the stroke is on your non-dominant side, it's going to affect visual-spatial stuff, which you might not even be aware of, and it's going to be your left hand. You're like, you ignore it. I mean, and again, it kind of depends on where the stroke is and how bad it is, but that is part of the truth. If it's your non-dominant side, you're just going to tend to be like, it's okay, I still got this one. So what they'll do is restrain the good one so that you are forced to use the other one. And it's, like I said, people can rewire. Sometimes we really can't do a whole lot about motor function, when people really are almost, paralyzed. But it's amazing how many people that's happened on their right side and they're, left dominant, so right-handed, that become functionally left-handed. And they'll tell you that. And you're like, I used to be right-handed, but not anymore. So they do at least have the capacity to do that. But what we're hoping is we get better with these techniques and we understand the science and the reality of trying to build these new pathways that will get them function back or more function back on that damaged side. I mean, it's great to have compensatory stuff. It really is. But the goal is to restore functionality. And so, yeah, I kind of defer to PT on that because I work inpatient. I do not do that kind of work. So, yes, I know it's out there. I listen to it when I go to my conferences, but I am not the person who does it day to day.
Fran, I want to thank you so much for being here. I am going to wrap up with our online audience and turn it over to you for any questions in person. Thanks again for being here. You always do a great job of breaking down these really, complicated and important topics. So I appreciate you. Thank you.
Bye.
Thank you.
All right.
So thanks for being here today. We look forward to seeing you again. We've got some more talks. We're going to be wrapping up Brain Health Month this week. I've got 2 more talks coming up. We've got deep vein thrombosis and aging, understanding the risks and solutions. That is tomorrow, Wednesday, March 26th at 3 p.m. with Dr. Cody Kramer. And then we also have on Thursday, March 27th, the role of PT after stroke, which Fran sort of alluded to as well. That is Thursday, March 27th at 10 a.m. with Geneva Kaplan-Smith. She is a physical therapist with our TMC adult outpatient therapy. She does specialize in stroke. So we would love for you to join us for that. If you are interested in one of these classes, please give us a call. The phone number is 520-324-1960. I'm also going to put one last plug in here. We have Stroke Prevention Saturday coming up on Saturday, April 5th. From 7:30 to 11:30 a.m. If you are interested in attending this year's Stroke Prevention Saturday, please give us a call, 520-324-1960, and we will get you signed up for a screening time to start the process. This does include free tests, including your height, weight, body mass index, blood pressure, blood sugar and cholesterol, and an EKG, along with a consult with one of our providers to go over those risks of a stroke. So it's a really wonderful thing. It is free to go through the screening. So again, please give us a call, 520-324-1960. Thanks and have a great day.